Hi, welcome, and special shout out to anyone who's a prospective TC student, because I was in your spot 4 years ago, and the academic festival was actually one of the many reasons why I chose to come to TC, because this is your opportunity to see some of the exciting and interesting projects that people work on here, and it's just been fantastic for me. I think my experience has exceeded my expectations, and not just because of the research that I've had the honor to be involved with, but also because of the friendships and the deep personal connections. And sitting here, that friendship started on the weekend of academic festival 4 years ago too. But we are at TC, and the education here is world class. And with that, you've all heard about our panelists here, who are much beloved. I just thought that some of you may not know exactly what these jobs do, so if we could maybe start off with Louise, and you could tell us a little bit about, well, actually just each of us, tell us what you do and what that might mean for somebody.
Okay, I was trained as a physiotherapist, or as you would say, a physical therapist, and I fairly early on developed an interest in the brain and how it controls movement, and therefore went into neurological physiotherapy, which is the treatment of disorders of the nervous system. And I particularly was interested in helping people who'd had a stroke, who'd had some sort of blood clot that's cut off the oxygen to the brain, so they receive some brain damage. And most people who have a stroke have some physical problems as well. They might also have other problems, cognitive and emotional problems, but mostly they have physical problems, and they're the problems that I'm concerned with. Particularly walking. Most of my research has been involved with looking at interventions to help people to walk again, but some of my research has also involved looking at the upper limb and working out how to get that moving again. Is that enough?
Thanks. Joe?
Sure. So as was described a little bit earlier, my research really focuses on using exercise as a part of a treatment, or the treatment for addiction and mental health disorders. So typically we see individuals, generally everyone that we see smokes, for sure. They smoke cigarettes and then they are doing something else. And so it's a matter of trying to figure out a way to weave exercise into someone's life to try to help them use that as a tool to manage their addiction and to manage their abstinence from what substance they might be using. And as you might imagine, individuals with addiction or substance use disorder often have problems with anxiety and depression. And so we also focus on that. I have an ongoing study right now that's looking at using weightlifting for men who are depressed. And weightlifting is the chosen way to exercise, and it has a good gives the individual a good sense of strength that they otherwise might not get from other types of exercise. So this idea that you might need something to help you feel strong with your feelings, with processing the daily stressors that you might have, it can be internalized as you're physically strong, and then you can become mentally strong. And so we sort of play off of that with our exercise programming.
Thanks. Debra?
Good morning. It's a pleasure to be here. So I finished my master's in what was then the Applied Physiology and Nutrition program, and also Pam was there that first day for me too, so maybe there's some connection. Usually Pam bringing everyone, in addition to President Furman for sure, and many others. That's a lovely introduction, thank you. I am the CEO of Wellness Workdays. We're based in Boston, Massachusetts, and we design and deliver employee wellness programs. So we work with organizations of all sizes to develop wellness programs to improve employee productivity and health, and really focus on developing a culture of well-being for those organizations. And then I am also the program director of the Wellness Workdays Dietetic Internship. So we focus on helping those individuals who already have undergraduate or graduate degrees who want to become registered dietitians. We help them go through their internship, we mentor them, and then help them to pass the exam so that they can be RDs in more, well, I don't want to say more innovative, but in some exciting areas, which include worksite wellness and health promotion, sports nutrition and entrepreneurship, nutrition communications and marketing. So that's, as you know, we were talking earlier, registered dietitians are doing a whole lot of things and a lot of different things over the course of many decades. So I'm excited to be here today to share some other thoughts on these topics with you.
Great. Maybe you could just tell people a little, I don't know, some people know that what a dietitian does too, but some people have no idea what a dietitian is.
So a registered dietitian, and that's sort of what's so interesting about it. Other terms you might hear are nutritionists. If you were at a hospital, you might see them nutritionist, but really that's a registered dietitian nutritionist through a national organization called the Academy of Nutrition and Dietetics. And so nowadays, it's not it's not uncommon to see RDs, if you will, working in many different capacities. And so you might see them at fitness centers, you might see them obviously in hospitals or physical therapy centers working on research studies. Last night, no joke, my daughter and I were at the Boston Celtics, and there's a sports RD who graduated our program, and he's now helping the Celtics with their nutrition and meal plans. And so there are many RDs across NFL and NBA and other sort of programs. So whether it's working with athletes or working with organizations to promote American Cancer Society or American Heart Association, community settings, schools, you'll find RDs working in food service and many different capacities. So it's really grown and blossomed. So gone are the days when it's really an RD is only going to be found in a clinical setting such as a hospital.
Yeah, and in the interest of full disclosure, I'm also an RD, and my work is, actually in a research setting in a hospital with a specific population. But so I'm just wondering if our panelists can tell us a little bit more detail about our work or their work. Debra's case, what is it that you're doing in a workplace wellness setting? We start with you.
Yeah, absolutely. So when we're partnering with an organization, we work with groups from 25 employees to 25,000 employees. And so we're really focused on something called population health management. Right? So we're trying to look at a population and determine how are we going to get them healthy or keep them healthy. So there's a lot more information talking about keeping healthy people healthy, because we know, unfortunately, as we age, our blood pressure tends to increase, our weight tends to increase, our body mass index, tell me if I'm misstating anything, our body mass index tends to increase, our muscle mass decreases. So all of these things happen, even if we lie about our age, it's still happening. So it's really important to focus on how do we keep a healthy population healthy, then how do we find ways to promote and inspire individuals to adopt and maintain healthy lifestyle habits, whether that's through nutrition or physical activity, stress management, resilience. So the real focus is, and the exciting part for me is to be able to work with the population. So as a registered dietitian, historically we're taught to sort of, work with one person, but working with a group, there's a lot of potential benefits. So when we're partnering with a company or an organization or a university, we're looking to figure out how do we educate the population and motivate them to want to, again, adopt and maintain healthy lifestyle habits. But it's not just the individuals we're looking to inspire, we're also looking to management, right, to support these efforts, to support their employees in their efforts. And so a lot goes into sort of developing policies and acceptable behaviors. I mean, it may not be acceptable to leave your desk at lunch, right? We might take that for granted, but that's not always the case in all worksite settings, or taking a half hour to go for a walk, or do something that's important for you, or taking time off to go see a doctor, right? Talking about care and self-care. So we're looking to really work with the organization and develop all of these aspects of wellness so so that we can really help the culture and the environment to help improve employee health and wellness.
Thanks, Debra. So, Louise, can you tell us a little bit more about the specific types of studies that you've done?
Yes, so in the last, particularly perhaps the last 15 to 20 years, most of the studies that I've done have been trying to look for evidence to work out what's best, what we should do to help people with stroke. And so mostly they take the form of randomised controlled trials, and as I said before, most of them are in the area of looking at walking, recovery of walking. But certainly, and so mostly they started out being trials that were set soon after people had had their stroke, in the first few months when they were undergoing rehabilitation, and they were in a hospital or in some institutional setting. And it was very much the case of, this is something that the therapist delivers, and we would be testing that, either something new against something that was more traditional. But now I think my research has shifted somewhat to looking more perhaps at a wellness model, more looking at what happens to people after they go home. They've finished their rehabilitation, both as an inpatient in a hospital and then even perhaps a few months of being an outpatient and having more therapy. But then they're at home, often with no further monitoring, and looking at this idea of physical activity, trying to get people to do more physical activity, partially just to be more healthy, but also to prevent having a second stroke. There's a reasonably high incidence of people having second strokes, and if we can help control their cardiovascular disease, not only medically by reducing their blood pressure and cholesterol, but also physically by undertaking exercise, particularly with a focus on not necessarily undertaking high intensity exercise, but being more physically active, sitting less and moving more. That's one of the slogans that's going around at the moment. And so we've been looking at particularly the idea of self-management for people to try and become more active and have that as part of their life, have it ongoing.
Okay, thanks. So, Joe,
Yes.
I think that probably transitions well to maybe what your studies are about. Can you tell us a little bit more detail about yours?
Sure. It somewhat does in the sense that that I study exercise. We don't necessarily look at the goal isn't to increase exercise adherence really, as it is more of is that better? Okay. As it is, as I said earlier, to use exercise as a tool. So obviously it's important to regularly use exercise over and over again as a tool. And so in some ways that is sort of adhering to an exercise program. But there would be a different theoretical approach if I were to just use exercise to try to get individuals to adopt an exercise program without using it as a tool. And so as using it as a tool, the idea again is that there's both a physiological and a psychological component that can happen in response to exercise. And so we try to play off of those things depending on what it is that we're studying. So the name of my lab is Resistance Exercise and Health and Behavior, or a rehab lab, basically is what we call it. And so that's using again exercise, whether we're treating, we have individuals that we have targeted with PTSD, depression, anxiety, HIV, young men with potential muscle dysmorphia or body image problems. So we run the whole gamut of individuals that do exercise and they have a problem with it, all the way to those that do not exercise but just have a problem with other issues like anxiety or substance use. And so we cover a wide range of topics, and we do, as I said, focus on resistance exercise. And again, that is one, oftentimes to give individuals a sense of strength, and that they are, again, physically becoming more strong as they are mentally, and that seems to be very helpful.
So it sounds like everyone said that there's a level of complexity to all of these different types of interventions or actions that you take. But so Joe, when you develop your studies, what kinds of things are you taking into consideration? It's very interesting that you would pair strength training with mental illness or addiction. So how did you get there? We talked a little bit.
How did that come about?
Yeah.
So really in trying to figure out, again, what it is specifically that I was looking at, whether it's actual addiction or there's a psychological disorder, it's really trying to figure out the mechanism of where exercise would fit in, so if it can target certain issues. So to give you an example, physiologically, I can just tell you in cigarette smokers, they have a high level of cortisol, and that's just as it's a response to nicotine. And when they quit, their cortisol rapidly drops because they don't have that nicotine in their system anymore. And the slope at which it drops, how quickly it drops, is really predictive of their withdrawal symptoms. And so we use exercise as a way to try to buffer that cortisol, and you have an increase in cortisol when you exercise, at least if it's an intense bout of exercise. So we use exercise as a way to increase cortisol along the way to try to help the level of cortisol slowly come down. So that would be a physiological mechanism in which we would use exercise to help somebody reduce their cravings, reduce their withdrawal symptoms, to quit. Again, psychologically, I keep beating the same drum here, but it is that with resistance exercise, individuals become physically stronger, and that is really, it resonates with individuals very quickly and much more quickly than aerobic activity seems to. And so if you can really feel your muscles and you can feel stronger, that does seem to translate psychologically to having increases in self-efficacy and self-confidence and autonomy and feeling more powerful. So there is this balance, again, depending on what area that we're studying, of getting a physiological and a psychological component to it and matching it up so that it seems to work or slightly help.
Could you just save questions for the end?
Well, no, because I need a definition.
Oh, okay.
Resistance exercise is defined quite differently by different people.
Okay.
Could you please tell me what you mean?
Well, it can be anything from body resistance to actually weightlifting, picking up dumbbells. So basically that. We've done both, tested both.
Okay, so you're including both. So normally when someone says resistance exercise, it doesn't include dumbbells.
It does.
Yeah.
It's resistance training, maybe, if that's, I'm not sure, maybe if you're thinking of it in that way. But you typically use resistance exercise would be a single bout of exercise. If it's a training program, we just say resistance training. And the idea, resistance versus strength, because it's not necessarily targeting, the goal isn't necessarily to target strength as it is to target a change in strength. And so there can be multiple types of resistance exercise that you can do for that.
Thank you.
Sure.
All right. So I think you also mentioned there was a kind of a progression in your studies, and now that you're looking more at people being independent at home, could you explain how you got to that point?
I think it was part of a general movement towards that was occurring across society and across the medical profession generally. It wasn't necessarily led by me, but it was also informed by the fact that when I did studies, not only in the more acute or subacute setting, when I was doing studies where people already were living at home, you get to have a lot of insight into what their life is like then. And you get a feeling of abandonment, I think, that while we have a very good public health system in Australia, there's a finite amount of intervention that they get. And while it's quite generous, it's probably up to about 6 months, about 3 months of inpatient rehabilitation and another 3 months of outpatient rehabilitation, which I think is probably more than most people get here. It still means that after that there's a fairly quick and decisive cut-off, as in that's it, and you're on your own, really. And so I think this idea of, well, what can we do to make people more healthy and so that they continue to be healthy, but not dependent necessarily on institutions. That is, in coming back and having a program run within an institution. And I think that's really where the whole idea of self-management came from, that people, if they were educated in terms of self-management and helped and supported, that they could then continue to exercise with a small amount of external monitoring, which of course is a lot less expensive than institution-based programs, and that this would then be beneficial because they'd be healthier generally.
Yeah. Okay. Debra, I feel like this probably follows up with you. So, you said there's a lot of moving parts. Basically, it's not just the person; it's also the employer and the support that they're getting. I don't know, how do you manage all of that and commit? I mean, some people or some businesses just don't have the money to be able, or they feel like they don't have the money. So I'm just curious as to what approach you have towards handling all those different pieces.
Yeah, and it's clearly a challenge. I mean, when you look at from the individual's perspective and they think, why aren't they exercising, why aren't they eating well, and they'll talk about sometimes budget, right? It's too expensive to eat healthy, or they'll talk about time or lack of knowledge or not clear priorities. And so when we then think about sort of how they fit into their environment, we work with employers to figure out sort of where they are and sort of where they're going. So I think a lot of what we see with wellness programs that, in the research, aren't working is because they're just throwing out an intervention. They're saying, well, we do yoga and we have a Weight Watchers program, and why aren't we seeing any changes in our culture or our healthcare costs or things like that? And why aren't we, recruiting different, top talent? And so, what we learned as registered dietitians and researchers, you don't just throw a solution to a problem, right? So there's something in clinical nutrition, ADIME, where you're assessing and diagnosing, setting up an intervention, measuring and evaluating. And we do that same kind of process with worksite wellness. And I didn't have that aha moment until I was invited back to my undergrad alma mater at Cornell and asked to speak to the clinical nutrition class. And I thought, what am I going to talk to them about, right? Because I really don't do clinical nutrition, as you heard in my intro. And so what I realized is that we deploy a similar kind of tactic so that we can be effective. So we use first an assessment and then strategize to figure out what are we trying to solve for. And then and only then do we implement or intervene. And that's when we talk about, what available resources you already have for your organization, what partners are local, what kind of organizations can possibly come in and help, what resources do you already have. As I mentioned, we work with many universities. Well, you have experts right on staff. And so, we're working with banks, and clearly financial wellness is a very important topic. It creates a lot of stress for most people. And so if you're stressed about finances and then you come to work, it might be hard to focus. So within that implementation piece, we're very sort of cognizant to think about, what's already available, what can the employer utilize as resources that they might already have. Many have an EAP program, which is an employee assistance program. Many have an insurance carrier which can provide services. And I mentioned there are many organizations that are providing health and wellness and education information. The challenge becomes piecing it all together so that it's strategic and comprehensive and you're getting towards those outcomes, because the final piece after the assessment, strategy, implementation is that evaluation. We need to know, did we get to where we're headed? Are we moving in the right direction? Or do we need to sort of change course a lot or little? So piecing it together is something, but as an aside, or maybe sort of to conclude my thought, is that when we're working with an organization, we ask them, well, what are you spending in healthcare? Invest a very tiny, much smaller percentage for your employees' prevention of wellness, right? Or not prevention, but prevention and promoting wellness. And so you're already spending, this money is flying out the door, right? In many cases for organizations, it's millions and millions of dollars. So focus on a little bit of prevention, give a small enough budget, and you can see some great results.
So I guess this question is to all of our panelists, but kind of building on Debra's response. I mean, addressing barriers and facilitators is challenging. I know you said you weren't, in your interventions, you weren't looking at adherence, but I mean, there must be some practical information that you could take away as an employer or as a healthcare facility to encourage people to be able to do what they need to do, and similarly, when people are going home, I mean, obviously, it's much less expensive to do the intervention at home, like self-care, which is what this is about. But getting there is probably half the battle. So either one of you guys.
I think in terms of the barriers, in terms of my particular interest in the population I'm interested in, which is people with stroke, one of the difficulties is that they have, depending on whereabouts their brain's been damaged, they can have a lot of different impairments. So while I'm interested in the physical ones and the fact they can't walk, I might also have to deal with the fact that they may not be able to communicate, they might have lost their language ability, they might have some perceptual problems so that they can't work out where they are in space, etc., etc. There can be all sorts of things going on, and that in itself makes it difficult. One of the things about self-management is for people to be able to take responsibility for their own health. That's really part of it, and that's not that easy if you have those impairments as well as the physical impairments. And also my 10 years or more ago, my mother-in-law had a stroke, and she taught me a lot. It was really interesting and difficult to be involved in someone's life on an everyday aspect of their life, of someone who'd had quite a heavy stroke. And what it really made me realise, and it's not that I didn't know this before, but it really brings it home to you when you see it, is just how difficult living with a disability is, in the sense that everything seems to take twice as long. So just the things that we take for granted, getting up and having a shower in the morning and getting dressed, ready to do whatever we're then about to do, can take twice as long. And if you start looking at that for everything that happens, it's really easy to see why people don't exercise. I mean, let's face it, we can have difficulty finding enough time to exercise and often give that excuse that we don't have the time. Well, imagine if you're living with a disability, that where every day part of your everyday life is taking twice as long as normal. So I think it's a difficult, those things are difficult to overcome. And so we're just doing a study at the moment with one of my PhD graduates has gone on to do a series of studies where we're looking at implementing self-management, and our main outcome that we're looking at is using step counters, how many steps a day people do. So we're not looking at the intensity of what they do, we're just looking at them moving more. And we decided to do this first study looking at people who had a very mild stroke. And these were people who might have been sent home within 10 days or 2 weeks. They didn't, in fact, have a severe enough physical problems to be sent to inpatient rehabilitation. They might still have problems, but they were mild enough to go straight home. And we figured that we'd start there, because if we could work out, if we could make it work there, we couldn't, and if we were having trouble making it work, we couldn't use the excuse, oh, well, it's because they've got all these cognitive impairments or because they've got all these other problems. It would be that we weren't doing it very well. And so we're up to, we've just nearly finished the phase 2 trial. We've done the phase 1, phase 2 trial, and then we'll be doing the phase 3 fully powered trial. But it's certainly looking promising that we are getting people who are trained in self-management to, over about 6 months, when we measure them down the track, they've increased their amount of physical activity. as in the steps per day they're taking.
So what is it that you are asking them to do that you think is sort of related?
Well, what we're trying to do is to educate them about the importance of exercise. Starting off educating about the importance of exercise in terms of their condition, and in terms of not only them being well, but in terms of heading off another stroke. And then really we work with them over a number of sessions to sort out a way where they can exercise in a way that they can continue. So helping them overcome barriers, working out how they might do it, what they might do, what's going to stop them, what's going to interfere, and how they might overcome that. You know, so even things like if they're walking, you know, they decide they want to walk around the block, they don't want to do something structured in a gym setting or anything like that, they're just going to walk around the block, and, you know, giving them different strategies to make sure that that'll happen. For example, having a walking buddy, so that person comes who might be more able-bodied, so they come and collect them at a certain time, and off they go, which means they're more like, as you know, if you do that, you're more likely to do it. If it's all up to you, it's raining today, it's cold, or snowing. So, you know, working through those sort of things. And certainly the anecdotal response we've had, as well as measuring that they have more, they're taking more steps a day. The anecdotal response is that, you know, they feel they can solve problems better. They feel now they're equipped to better solve problems, and not just give up either.
Okay. So this is very personalized to their situation, where you're going through it all. And is this something that you lead? Or you give them ideas for this walking buddy, for instance, or these are solutions that they come up with themselves?
Both. So the idea is it's an interaction. So I think in the past, therapists are by nature bossy. I think that attracts people who want to do the best by their patients, but are also fairly bossy. I think we've been fairly controlling. We know what's best, you know, this is what you do, sort of thing. And I think this is a change, and it's not even just getting the patients themselves to come up with ideas, but their family as well, their friends and family. It's the idea that it's like having a brainstorm, and the therapist might put some ideas in what'll happen when this happens, or they have a go at it and things happen, and so then you have another session and work out. But anyone can contribute to the brainstorm that's around, basically, as long as the barriers are overcome, that you come up with some strategies.
Right.
And in that way, there's a system that we go through, but it's highly personalised, as you say, to that person.
Right.
What suits them.
And it sounds like it's also a very different approach from what has been tried in the past, where the therapist had been telling you do this and it doesn't work, and then nothing happens.
Well, it wasn't so much that when therapists told people to do things that it didn't work. It was more the issue that once people had gone home and they were on their own, the health system had now abandoned them, they didn't keep it up. I think personally, it's very difficult for someone to suggest that you have to do something forevermore.
Yeah.
And you say, great, can't wait to start. Whereas if you've got a goal, or and that's really what we're telling people, you need to exercise forever. Whereas it's much easier to do something if you've got a goal. You know, you're going on some bushwalk, or have that expression, a backcountry walk or something, in 6 months or something, then you're more likely to get out there and do some training. You're going to run a marathon, you're going to go in for a knee operation, whatever it is. There's a finite time, and you can get right into it. So I think that there still needs to be some external monitoring, even if it's not very often. But it doesn't necessarily also have to be a person like it was in the past. You know, there are so many situations now where if people wear the Fitbits and things like this, that they can, they can graph them, they can put them into their computer, they can see what they're doing, and it's they can't escape if they've started dropping off. They can't escape this, but even if they do that and then send it to someone and they get some reinforcement, I think those things are really helpful as well.
Right, so I would agree with that. I think that it's just a puzzle, at least with respect to exercise, and trying to figure out for your life where it fits in and how to fit it in. And so whether it's with social support is the key for you, or having a Fitbit that helps you keep track of your activity, or whatever it might be. A lot of times it's the motivation that individuals lose, right? So you might exercise, but then it just slowly tapers off because you lose interest in what you're doing. And so then you have to find out a new way, a new thing that will keep you interested in doing something else. And I think training is often really good for a race or a marathon or whatever it is that you're doing, some kind of competition. It seems to be a little bit better for men than it is for women. Women tend to go more to the side of they're more interested in being part of a group and do something that they can receive some kind of social support with. But one of the things that's sort of long term, I think something I can speak to a little bit is impulse control. And so individuals who have problems with impulse control are individuals that I often see. And it's really about figuring out the cues to what is driving your impulse. So your impulse just doesn't necessarily happen as it is. It's often post some other event. So for instance, individuals that have problems with substance use, being in a bad mood, being hungry, certain emotions or moods that you might have will precede this. And so it's a matter of paying attention to that and understanding, when I'm angry or when I'm hungry, then I tend to go towards this, or I start to do this, or my pattern is something that goes down a worse road. And so figuring those out, oftentimes people don't think about what's happening. They don't actually view their behavior in that way. But thinking about what's actually going on prior to the event, I think, is particularly important.
Did you want to add to that?
I did, because I think sort of, if we think sort of the common thread is sort of, the length of kind of the commitment and the short-term versus long-term goals. And we find that also with our work in worksite wellness, I've come to organizations that have an existing program and they say, well, we've been running this 52-week program and we're just wondering why people drop out after, X, Y, or whatever week it is. Thinking, well, you're asking somebody to do the same thing every day the entire year with no difference, no change, no excitement. And so to just, stick with, one thing long term as far as like an exercise or even eating regimen, can get, I think, boring or just monotonous or just reachable. And so something that we'll do with sort of our interventions is do sort of, we go in and go out, I kind of joke like that. So whether it's a short webinar, and webinars and seminars used to be 60 minutes, and then they were 45 minutes, that was too long for employees, and they were 30 minutes. And I have employees that say, well, can you give me, 12-minute, webinars? Like, sure, let me teach you everything you need to know about managing your diabetes in 12 minutes. How to start an exercise program in 12 minutes. So everything's gotten shorter, attention spans, and thus, 140 characters on Twitter. Anyway, so, we'll do programs and vary the content and the approach. So it might be, let's say, a 30-minute, web-based topic, or it might be if it's a long program, a 6-week intervention. 12 weeks is very long nowadays, not for a research study, but to go on site or to ask somebody to participate, let's say in a program to manage their diabetes or to focus on weight management. So if it's a 30-day superfoods challenge or a 30-day mindfulness challenge where each day you receive an email and some background information or a booklet that you follow and track one activity over the course of the 30 days and try to achieve, let's say, 15 to 20 new activities or try 15 to 20 new foods. It's short and sweet. And then they've learned and they've achieved and they feel confident that they can do this. And then we, like I said, we go in, we come out, and there are raffles or prizes or something fun. For, you get a lanyard or you get a chance at a gift card or, something fun. And then we move on to another topic where we're educating and hopefully educating and inspiring on a different aspect of wellness. So it's just very interesting to hear the different sort of, you know, applications and approaches, but a similar kind of a focus, like you said, to, you know, do this forever. Will we be successful, or, you know, you're going to do this every day, maybe not sort of what we're planning, you know, to be successful.
Yeah. Really interesting. So are you saying that right now, like, what does your typical, like, intervention look like? Actually, also, I'm just curious what people can take away from this, as, you know, when they walk out of this room. You mentioned for women it works a little bit differently than for men, and I think you're saying the same thing. You have to all find something that works for you. Trying to customize it in a way, empower yourself. Just wondering, how would you maybe translate that?
Right. I think with respect to time, I guess everyone I don't know, we sort of seem to be coming back to exercise as a, I don't know, maybe also eating well.
Yeah, diet.
There are different barriers for that, and usually access. And so I can't really speak to that. Maybe you all can.
Yeah.
But with respect to exercise, I mean, sort of everyone says, well, time. I don't have the time. I mean, and that often is just that you don't have it as a priority. So you have to be real with yourself. Mm-hmm. And we don't have time to do anything. And so you spend time brushing your teeth each day. Mm-hmm. And so you figure out a way to make that happen. Mm-hmm. Granted, it's a shorter period of time, but it's a priority, so at least most people do it. And so
Flossing is a different question.
Flossing is a different question, right? It's a different thing. It's just a matter of what gets the job done. And so I think that's a great example, because oftentimes people will brush their teeth, but they don't floss because it's that extra step. And so brushing your teeth can maintain your teeth without having to floss them. Well, you can maintain your health without having an extensive exercise program where you're constantly exercising. You can still be up and moving around and being active. And that is actually benefiting your health and reducing your risk for a bunch of different diseases. You don't have to it is very daunting to think that you have to exercise so much and for the rest of your life. That's so overwhelming for so many people that then you lose your motivation and interest. I mean, basically it becomes this learned helplessness. No matter what you do, you can't get ahead. So I would say don't think of it in terms of that as you have. It's just a matter of what can you do today, if today is a possibility. Mm-hmm. But this idea that time is a problem is not, nobody has time for anything.
Yeah, I think
it's habit. We clean our teeth because it's habit. Because it became habit when we didn't have control, because our parents made us do it as children.
Well, there's also immediate consequences too. You see the consequences pretty quickly.
But maybe that's what we have to do, is make exercise a habit, so it doesn't become something that you think about too much.
Yeah.
And it's like today what was that thing on the mantra on there was take the bus, not a cab. Well, the other point about taking the bus is it usually doesn't take you to your door. So you get incidental exercise. Take the stairs, not the lift. It's the same thing. I think these activity monitors, Fitbits and stuff have really changed exercise. That non-structured exercise for a lot of people. I know that my friends will say things like, "Oh my goodness, I haven't done many steps today," as they look at their thing, and they'll go off and they'll go for a walk, which they wouldn't have done. It's been triggered by the fact that they've got some information that tells them that they haven't done very much.
Yeah, I think I don't think I've spoken much on diet, but it sort of works similarly. I think people who just build it into their lives, who, normally, if you use the My Plate tool and you look at your plate and you say, okay, half my plate's going to be fruits and vegetables, and a quarter is going to be a protein, a high quality protein, and a quarter a high quality grain, and you always think, oh, that's what my dinner needs to look like. Now, what do I need to do in my life to get there? And so that means you're not thinking about dinner at 5:30 and you plan to eat at 5:35. You've put a little bit of thought into it and gone to the grocery store and stocked your pantry so that if you're running late, you can pull something out of the freezer, or you have some whole grain in your pantry already that you can pull together a quick and healthy meal. without a lot of effort instead of like reaching for that bag of chips. So yeah, that's part of it. I think we only have 15 minutes left, and I just want to end with like asking one more question of the panelists, and then open it up for questions for you guys to ask questions in case we didn't reach exactly what you wanted to talk about. And that would be like, what would be the key takeaway that you would want people to think about? I know most people, I want to say it was like 5% of people in this country at least, do the required exercise and healthy eating and all the things that they're supposed to do for their lives. So in just a few sentences or so, could you give some advice?
Move more, sit less, make exercise habitual, make it part of your life. And the studies on sitting less, what they show is that, the studies that were done, they basically got people, these are people not necessarily with health conditions, just ordinary people, and they'd make them sit all day, and then they'd get them to get up from sitting, and they'd measure all sorts of physiological responses. But the interesting thing to me that came out of it was that as long as you got up, it didn't matter what you did when you got up. You didn't have to do, 180 heart rate strenuous exercise. You just had to get up and either stand or walk or do something, and it offset the amount of time that you sat down for. And that's really one of the reasons that we're looking as our main outcome of steps per day is not necessarily that people are doing strenuous exercise, but just that they're moving more. And also one of the things that we often get people to do, if they've got some of those monitors you can set in different ways, and one of them is don't sit for more than 30 minutes, which we've been doing, haven't we? That you can put those alarms on or something, and it's like Pavlov's dog, you learn, so this alarm goes off and you stand up.
Okay. Joe?
I guess it's difficult because it really depends on your issue. I don't sort of what's my general advice for life. I mean,
You could break down
be
people
happy,
in little categories.
try to be as happy as you can. I guess I think the most important thing is to pay attention to what you're doing and try to figure out why you're acting a certain way. So if your behavior is not in line with what you want it to be, then again, try to figure out what are the cues to the things that make you act the way that you act. What are the things that are getting in your way, and is there something that's the largest barrier that you could break down, if you think of it in terms of the strength of each barrier, or sort of put them in a list of the smallest to the largest barrier, and either tick off at the bottom, get rid of the smaller ones and make small changes, or try to go for the big giant one at the very top that will have a really dramatic effect. So I'm not sure, but I do think that oftentimes you just get caught up in, well, that's just the way that it is and I accept it. And so if you can really try to figure out why you're behaving the way that you're behaving, that might be helpful.
Interesting.
So I guess my one piece of advice or sort of thought is to think about, big picture first. As a registered dietitian, I would often, through my years of counseling, somebody would come to say, do I really need to add chia seeds to my diet? Or should I really be switching to this specific canola oil or this oil? Or, do I need to lift this brand of weight, use this machine versus that machine? And really, they're forgetting the big picture. Or do I need to supplement? And they're forgetting. So my message is typically, let's first think about, what's the most important area of focus, which I think you said earlier. What's the most important thing that's going to affect you most, whether it's your sleep pattern is off, or if it's nutrition, physical activity, is it stress? What is it that you need to focus on that's going to have the biggest impact on your life? And typically, you don't need somebody else to tell you that. Sometimes you do, but most often you know what the area is. You may need an expert to help you define it, but like with nutrition, you mentioned earlier, eating whole foods, focusing on less processed foods. Forget about sort of the new research study that's going to come out tomorrow telling you to switch from this seed to that seed. We know enough about healthy eating, I'd say, with all the RDs in the room, that we don't need necessarily, to really worry so much about what is appropriate nutrition. We know the answers. So let's just focus on setting a priority for yourself. Is it nutrition? Again, what's the best exercise? How many times have you heard that? Best exercise is the one you do, right? So that's really, right? And so I think that's, set a priority, figure out what's going to help you the most in your situation and tackle that. And don't feel like you need, to get down to the milligrams or micrograms of a nutrient or a supplement to give you the right answer, but instead think big picture and figure out how to get there.
Okay, so just want to thank the panelists, but also you guys feel free to ask questions, but just a little round of applause for them. And if you have any questions, feel free. I'll get to you.
Jen, I wanted to ask you to address, I was really intrigued by the title of the research that you're doing about hypervigilance and adherence to a medical regimen related to lifestyle. Mm-hmm. And Debra kind of touched on that with the last things that she was saying, but at what expense are some people, especially people with chronic illness, focusing so inwardly instead of on what makes their life vital or what their values or passions in life are?
Mm-hmm. So your question is, what are our findings about why people who have chronic illness will become kind of hypervigilant?
And specifically how that lowers the quality of their life, the hypervigilance.
Okay, so what we've discovered is that when people have diet-related, especially diseases, but probably any chronic disease these days has some diet component, a lot of times practitioners will focus on, this is what you need to do. And people will basically kind of obsess about it to the detriment of their quality of life. That's kind of as simple as it is, and that affects your anxiety level, can raise your anxiety level just in general. So for instance, with celiac disease, people who have celiac disease, the only treatment for celiac disease is to maintain a gluten-free diet, and gluten is found in wheat and rye and barley. And mainly the problem is that there's cross-contamination. So, people can become very fearful about going to restaurants, and they just live kind of a normal life when they start thinking about their meal, like their dinner meal when they wake up in the morning. Everything is about the meal instead of just living your life. And I think Joe said, you need to work on happiness. That's not something a doctor will necessarily say to a patient. Hey, you need to live your life. Yes, you do need to be careful about what you eat, but as Louise said, it can become habit. It doesn't have to be all-encompassing. There are things that you can do if you work with a therapist and maybe a dietitian. I'm not saying you have to see them every day of your life, but until you become confident about your routine and your habit, about how to maintain that diet and a healthy life, that will lead to a great quality of life, actually. And then the patients that we see who are working with people, they tend to have better quality lives. Does that answer your question?
Yes.
Okay.
Yeah, Professor Ciccolo, or is it Ciccolo?
No, that works.
Ciccolo.
That's it. Yeah.
So if I heard you made reference to applying exercise to treat or manage dysmorphias. Did you use that term?
I did, yes.
Would you like to explain that and elaborate?
Sure, yeah. So we've done a couple studies with young men who have symptoms. They haven't been formally diagnosed, but they have symptoms of muscle dysmorphia, right?
What is dysmorphia?
So basically, it's just, well, for these individuals, is that what they see in the mirror is not reality, and so when they look at themselves, they believe that they are very tiny and small. Their muscles are small. Okay, and so it is with respect to treatment, that particular area of study, we're not using exercise as a treatment. We're trying to taper the exercise because it's typically excessive exercise to the point where it can become dangerous. And it's obsessive in that it's regular and it interferes with other aspects of their lives. So they will be at the gym instead of being at somebody's funeral. Okay? So with that, we're just trying to figure out how to manage exercise in individuals' lives so that it's a manageable life. Harm reduction basically is that we're not trying to take exercise away, but to make it manageable for them so that it doesn't cause them harm, basically.
Yeah.
Hi guys, my name is Chris Hanna and I'm from LA and I'm going home in 15 minutes and I'm going to be a student next year at TC. If my parents agree to pay. And so my question is, it might be a little random or off topic and I'm not even sure if you can help me with this, so please excuse me if it is a little too much off topic. But I turned 23 on February 27th. And the day after my birthday, I decided to delete my Facebook and my Snapchat. And I also decided to start a new diet, which consists of intermittent fasting. I don't know if anyone actually knows what that is or even agrees with it. If you do know what it is. And then also, I decided to go to the gym and I get a gym membership and I'm swimming every day now too, which I really like. It's not even a super intense workout, but I do swim and I just find that I like that idle time to just swim. Not even at a fast pace. And I just feel better. I notice my skin is better. I notice I'm happier. I'm more energized in the morning when I wake up. And I just feel that there's much more of a structure to my life. And I'm just wondering if any of you guys can give me some answer as to why I am happy.
Okay, so your question is, you gave up your social media, you're eating healthier and you're exercising, and you're wondering why you're happier. I think you kind of answered your own question.
That's why.
Because actually there have been studies that do associate lower quality life with social media interaction. That's one. And then exercise, I mean, you got to increase. If you're increasing your exercise, you're probably going to feel happier from that. And diet, actually, I could have a whole nother talk on microbes and what you're eating, but if you're eating healthier, you actually will feel better. Then your gut microbes do control your brain too.
And you think that the social media might also have a hand in
Yes.
that? I just got sick of it. I was
Yes.
like, what? Literally
Yes.
like
Yes.
6,000 people.
So we have time for maybe two more questions. So
Hi, so each of your research seems pretty specific to certain communities, but I was wondering, what has been your biggest takeaway for each of you individually that you've adopted that maybe plays out in your daily life or your weekly life? What have you found really useful for yourself?
okay, quick.
I'd like to not have a stroke. And if that involves being healthy and eating better and not having cardiovascular disease as a result of eating fatty foods and that's what I'll do.
Yeah, I like to practice what I preach. So yeah, I eat well. I'm still working on the exercise thing, actually.
Yeah, I think it's important not to judge yourself, that there's no good or bad, that you just try to do the best that you can do, and try to do that each day.
Yeah, and I think it's important to talk the talk and walk the walk. And with my dietetic interns, and I say this, it never gets easier. You can't say when I finish my undergrad program, I'm going to start exercise, healthy eating, or when I finish my master's program, I'll start exercise. When I finish, I get through this first year job, when my kids are older, it's now, it's here. And so I've done counseling with people all ages and just various factors. We all have to figure it out, and kind of I take that to heart and use that as an example for myself and people that I work with, my interns and employees.
Okay, and right there. Yeah.
Hi, my name
You
is
got your hand up.
Yeah, we'll get. Yeah,
and
sorry.
I'm a newly admitted student My question is for Debra about the wellness and how wellness is such a trend in today's society. I'm interested in wellness and specifically mindfulness. How does the market respond to you going into different organizations and schools? How are they able to say, yes, we have the money for this program? And are most of your new clients by word of mouth, or are you just actively trying to customers?
Yeah, so I think that the market is clearly growing in the areas of worksite wellness because, I mean, just as we're here talking, I mean, nutrition, physical activity, resilience, all these things are real life issues that plague everybody and it knows no boundaries. And so it's a constant struggle. I think more and more employers appreciate that and realize that, you know, wellness is something that we can do for our employees, not something we're doing to our employees. And so that approach has really been, you know, embraced by our clients and our partners. You know, that's kind of who we look for. So a lot of our clients, to answer your questions, comes from, you know, other clients, or if you know, somebody's at an organization, they leave, you know, they bring us to the next organization because they like the way, again, our philosophy and our approach is to help and really work with employees, figure out what they want and what they need and give that to them. So mindfulness is clearly a key component of an overall wellness, you know, program and focus. So kudos to you. Keep it up. Yeah.
Okay, last question. Sorry, can we answer yours afterwards? She had her hand up first. Sorry.
I'm also newly admitted to Celiac Teachers College. I had a question for Louise. Actually, I was wondering, how do you make a personalized plan for stroke patients that have had a stroke that have lost speech ability? Like, how do they have agency over their plan, or is that possible?
Yes, I mean, as a physical therapist, I've become quite good over the years at getting around different sorts of language problems. But I mean, the first thing you have to do is to go and find out from the speech therapist exactly what their level of disability in language is, because as people may not know, sometimes the language difficulty can purely be that people can't express things. They can actually understand everything that you say, but then there are other areas of the brain, if they get damaged, they can't understand what you say, and therefore their expression becomes somewhat nonsensical. So you have to understand exactly what their language impairment is to start with. And if it's very severe, I mean, it's difficult obviously, but if it's fairly severe, then I would get the speech therapist involved in doing that, because they will usually have set up some form of communication, even if it's a communication board, that is, that they're not communicating by using language as you and I do, but they're pointing to things. And sometimes that's where friends and family come in, because they'll know them, so they will have known what sort of things they like to do before their stroke, and therefore then we try that, and if it doesn't work and they're giving us, you know, these non-verbal cues that that's not what they want to do, so you get around it by a lot of non-verbal communication.
So thanks everybody.
I just want to, let's give a round to